If there's people on, let me know if you can hear me okay. Hi there, can you hear me okay? Great. Where are you from? Oh, welcome. Okay, just gonna wait till about 12:05 to start, but we're gonna talk about lung transplant imaging. Are you a radiologist, Zafar? Oh, okay, well, welcome. Just have to make a phone call. We're going to start at about 12:05, just to give some more people time to log in. There's about a 10-second latency also, so just keep that in mind. If you post a comment or a question, there's going to be about 10 seconds before I see your no, actually, your comments are going to be immediate for me, but I would have already talked for 10 seconds. Based on the video that you're watching. I'm from Chicago, Northwestern Hospital. Okay, if you're one of my residents, then just put something in this chat so that we can record your attendance. Okay, let's go ahead and start. This first question is just kind of a warm-up question. Where are you watching this video from? And I'm guessing 90% of you are watching it from here, and then 1%, which may be one person, is watching it from somewhere else. Okay, so this talk is going to be about lung transplant imaging, and let's start off with a couple of questions. So this is my first question here for you. What is the most common reason for lung transplantation? Let's see what everybody thinks here. If you're logged into the video, open up a separate window so you can respond to these poll questions at pollev.com/rishi. Give y'all a little bit more time here. Okay, so we'll get to that. Most people said COPD. The second question is, what is the average 5-year survival post lung transplant? Okay, most people said 50%. Some people said 75%. And let's go to the next question. Single lung transplant is contraindicated in which group of patients? Okay. Oops, not supposed to do that one yet. All right, so let's talk about those questions. Oh, but first let me talk about the first lung transplant. So the first lung transplant was performed in Mississippi, and it was actually performed on a prison inmate who died 18 days after the transplantation. So we probably wouldn't be able to do experiments on prisoners nowadays, but that was first person who got the first lung transplant, and his immunosuppression was azathioprine, prednisone, and thymic radiation. And but the first successful transplant, which successful transplant was is described as a transplant in which the patient survives for more than a year, was done in 1983, and that was done at the Toronto General Hospital. And this is the picture of the first lung transplant. I really can't make heads or tails of this, but I know this is probably the right upper lobe, because I think there's a minor fissure here and a major fissure here. But the most common reason for lung transplant, this is a little bit outdated, but the most common reason for lung transplant is COPD, emphysema bronchitis. Okay, so that's the most common. A close second is IPF, and today this gap between COPD and IPF is narrowing a little bit. But those two account for the most lung transplants. And then you have cystic fibrosis, and then a small percentage of patients are other things like end-stage sarcoid, idiopathic pulmonary arterial hypertension. AT is alpha-1 antitrypsin deficiency, but there you can have a whole host of other types of interstitial lung disease, occupational lung disease as causes. But the vast majority of patients are going to be from COPD and IPF. And there's some absolute contraindications to lung transplant. These are some of them, but not all of them. Active malignancy, active infection being sort of obvious ones. But if you have any other organ failure, that is a absolute contraindication to lung transplant, like heart failure, liver, GI, renal. And then, of course, if you're a substance abuser, and you have to have quit smoking for at least 6 months to get considered for lung transplant. And then obesity, cachexia, and then diabetes. So contraindications to a single lung transplant would include cystic fibrosis. Okay, cystic fibrosis is a contraindication to single lung transplant because you don't want to damage the transplanted lung by the soiled native lung. Okay, lung transplant lung transplant patients fare worse than other types of transplant. So kidney is probably the best, high 80s in terms of 5-year survival. Pancreas, liver, heart in the 70s to 80s. Lung is a little bit over 50% 5-year survival. Okay, so it still has a ways to go in terms of catching up to the other major organ transplants. The main surgical approach that's used if it's a bilateral is something that's called a clamshell sternotomy. And a median sternotomy is what you see in patients who have CABG or some kind of heart problems. And that's a type of sternotomy in which it goes down the middle of the mediastinum like that. A clamshell sternotomy goes across the lower part of the sternum like this, and actually it's extended across, and the chest is open sort of like a car hood, and it's open like this. Okay, and that allows access to the more lateral aspects of the mediastinum, particularly the hyla. So if you're doing a bilateral lung transplant, you're usually going to be doing a clamshell sternotomy. Okay, whereas a single lung transplant can be approached with a posterolateral thoracotomy via the fifth intercostal space. Okay, and this is what a clamshell sternotomy looks like. So you're used to probably the sternotomy wires going like in a vertically oriented this way. So a clamshell sternotomy will go this way, horizontally. And pretty much almost always, if you see a clamshell sternotomy, then that pretty much almost always means that the patient has had a lung transplant. Okay, there's a few other indications that that are a lot less common. Like if a person for some reason needs a bilateral wedge resection, then they might get a clamshell sternotomy. But like 99.8% of patients who have a clamshell sternotomy, it's because of a lung transplant. I made that number up, but it's something like that. Okay, so let's talk about the complications of lung transplant. And there's different ways to think about the complications of lung transplant. And one way to do it is to think about the time course, so immediate, early, middle, and late. And this is one sort of useful way, particularly if they're in the immediate postoperative period, because a lot of these immediate complications are very unique to like the immediate postoperative time periods. But these later ones, like early, less than 6 weeks, and middle, there's a lot of overlap among these. So, as you get later on into the postoperative period, this early, middle, late becomes a little bit less useful, and because there's so much overlap. So the way I remember it, and the way I think is easier to remember it, is by thinking about these complications in terms of their category. So we can talk about surgical complications, infectious complications, immunologic, neoplastic, and other. Okay, and if you do it this way, for me at least, it's easier to remember these complications. And then within each section, you can remember, oh, this is something that happens earlier, or this is something that happens later. Okay, but we'll talk about all of these categories. So let's start with surgical complications. And so this is what it looks like. Basically, in the immediate postoperative period, this is what your immediate postoperative chest x-ray is going to look like. Okay, you're going to have an ET tube, there's going to be an NG tube, there's going to be a swan, and then there's going to be bilateral chest tubes, both at the apices and at the bases. Okay, and these are all placed intraoperatively, so most of the time, there's not going to be any problems with them. But occasionally you can have, something that's going in the wrong place, like the swan is going out too far, or the ET tube is going into one bronchus rather than in the trachea. Okay, so in the very immediate post-op period, watch the lines and tubes and make sure they're in the right place. Another sort of immediate complication is a size mismatch. This happens less now because the size of the donor and recipient are matched, and you can see in this picture here that these lungs were a little bit too big for this patient. So these are staple lines over here and over here. Maybe it's hard to see actually on the YouTube feed, but these staple lines represent wedge resections where they're trying to they're trying to size down the lungs for this particular patient. But anyway, a size difference of 10 to 25% is acceptable. What you don't want are lungs that are too big for the recipient, because that can lead to atelectasis, chronic atelectasis, which can cause impaired clearance of secretions and things like that, and repeated infection. Lungs that are too small are a little bit better than lungs that are too big, but if they're really too small, then they can be hyperinflated and they're at increased risk for torsion. Okay, but usually we don't see too small lungs. More frequently, I'd say we see lungs that are too big, and there's chronic atelectasis at the lung bases. Okay, so here is the next question, which is true or false: the bronchial arteries are anastomosed during lung transplant. Okay, most people said false. I'm not sure how many people have responded here, but most people said false here. Let's go on to talk about the bronchi. So bronchial anastomotic complications are probably the most common post-surgical complication that you'll see. And these are varied, and they're kind of varied based on the time. So early in the postoperative course, it's infection, necrosis, and dehiscence, and then like rarely torsion. I haven't seen a case of torsion personally. And then late in the post-transplant course, it's going to be granulation tissue with strictures, and then tracheobronchomalacia and fistula formation. Okay, and usually these are done end to end. Telescoping was sort of in fashion for a while, and then now it's not in fashion as much anymore, because telescoping has been associated with a little bit increased stenosis rates, but you might see either one of these, okay? So this is an example of telescoping right over here. So you could see that there's one bronchus that's inside the other bronchus here, and this one is one bronchus inside the other bronchus. So this shouldn't be confused for excess granulation tissue or stenosis if it's telescoped. And what you should do is look at the coronal images to kind of sort that out. But and then another thing that you'll see early on that shouldn't be confused for stenosis is edema. Like in the first about week or so after the transplant, you'll see edema around the bronchi, and the bronchi might look like they're narrowed. But if it's within a week, then that's probably due to edema. Like in this patient, it looks like this bronchus is a little bit narrowed. This one might be a little bit narrowed, but 1 month after surgery, the edema went away, and you can see these bronchi are widely patent. Okay, so the thing with the bronchial complications is that most of them look the same on CT, which is there's going to be a little bit of irregularity of the bronchus, there's going to be a little bit of bronchial wall thickening, and you might see some endoluminal debris, like ischemia with scarring, necrosis, a mild granulation tissue, infection. They're all going to sort of look the same, and that's why bronchoscopy is really the method that is used in order to diagnose these anastomotic complications. Okay. However, dehiscence, anastomotic necrosis and dehiscence is something that we can see early, and we can diagnose early, even prior to bronchoscopic diagnosis. Okay, and this is basically coming apart of the anastomosis, and it's probably secondary to ischemia, because the bronchial arteries are not anastomosed. Okay, the bronchial arteries, rarely are they anastomosed, and like 99% of the time, the bronchial arteries are not anastomosed because it's technically difficult to do. These are small arteries, and it increases the potential ischemia time for your transplant. But anyway, anastomotic necrosis and dehiscence is 2% of transplants, and it happens within 2 to 8 weeks after transplant. And the clinical sign is that there will be a persistent air leak if the patient still has a chest tube in place. Okay, but the air can go into the mediastinum, it can go into the pleura, it can dissect in all sorts of places. So, and then it can lead to fistula formation. So this is one of the later complications of anastomotic necrosis and dehiscence, is fistula formation. But basically what you're looking for on CT is a hole in the bronchus and air in the wrong place. So in this case, there was a hole in the bronchus anteriorly here, and then there was persistent air in both the right and left pleura. And you can see this patient has bilateral chest tubes in place. And I'll just show you more examples. So on this chest x-ray here, there's a deep sulcus sign for a pneumothorax in a supine patient, and you can see that there's a little bit of lucency over here, and that is either air in the mediastinum or air in the medial pleural space. And if you look closely at the bronchus, you can see that there's air extending, a linear area of air extending directly from the bronchial anastomosis here. And here's another example of one. Okay, Bronchial wall defects, what you should do is measure them, like where they come off at the ostium. And a bronchial wall defect of less than 4 millimeters is tend to have good prognosis. Okay, but really the way that these are graded is by bronchoscopy. There's grades 1 through 4, grades 1 through 2, and it's all based on how much like sloughing of the mucosa and how much necrosis is seen. So grades 1 and 2 can be treated conservatively, but usually grades 3 and 4 are deemed more severe, and those cases require surgery. And the mortality and morbidity of the grades 3 and 4 vary a lot depending on other factors. But usually if it requires surgery, that's a bad prognosis, obviously. Okay, and here's another example. So anastomotic dehiscence right here. Okay. Okay, and then so bronchial stenosis is the kind of long-term effect, okay? And bronchial stenosis is something that happens 2 to 9 months after transplant, and it affects 10 to 15% of lung transplants. And this usually occurs at the anastomosis, but it can occur distal to the anastomosis as well. And there's many reasons why a bronchial stenosis can occur. There's increased risk if you have a previous dehiscence. There's increased risk if you have an airway infection like aspergillus, airway aspergillus. And one of the signs that you might see on chest x-ray that you'll see before getting a chest CT is areas of repeated or recurrent post-obstructive pneumonitis or atelectasis. Okay, so that might be the only sign on chest x-ray is like a lobar collapse or a segmental collapse or a lobar pneumonia or segmental pneumonia. Okay, but you could see here's like an area of decreased of stenosis. And what you want to do for these areas of stenosis is measure the diameter. A diameter of greater than 50% is called severe, and a diameter decrease of less than 50% is mild to moderate. Okay, another tip for these bronchial stenoses is you want to look at the coronal images to make sure that you're looking at an actual stenosis and not just a size difference between the donor and the recipient bronchus. Like in this case, the donor bronchus, the donor lung really was a lot smaller than the recipient. So you could see that there's like this shouldering or this shelf at the anastomosis here and here. Okay, so what you have to do to determine this is look at the postoperative, the postoperative images. So, 1 month out or 2 months out, if there's a CT, then you can tell, is this getting worse or has this been like this the whole time? And this is just how their bronchi look. Okay, so be careful in calling a bronchial stenosis. Look on the coronal and sagittals and make sure you're not looking at just a small bronchus anastomosed to a larger bronchus. Okay, but here's an example of a severe stenosis where there is greater than 50% narrowing. And then here's another example, okay, and here's one that's distal to the anastomosis. This is going to be in the bronchus intermedius. Okay, and here's another example. So in this case, this patient was an attempt at stenting was done here, but it was really kind of too late. The right lung was totally collapsed, and it's made worse by the fact that the native left lung was hyperinflated, and it's causing shift of the mediastinum to the right with volume loss. Okay. Okay, and then bronchomalacia is another later complication of lung transplant, and this can basically is something that you diagnose on expiratory images, particularly forced expiratory images. And what you're looking for is a reduction in the cross-sectional size, cross-sectional area of the trachea. And the criteria differ as to how much of a size decrease there has to be, but generally, like if you're looking at diameter, then 50% decrease in the diameter of the tracheal lumen. Okay, and if you're looking at the lung, then you'll see areas of mosaic attenuation, which represent air trapping. Okay, so bronchomalacia can occur because of ischemia, because of repeated infection, but this is a relatively common complication, not as common as stenosis, but relatively common. Okay, back to questions here. What is the term used when the right and left pleural space are connected? Buffalo chest. Some people think it's a pig chest. Nobody thinks it's a mouse chest. Bovine chest, perhaps? Okay, nobody likes mouse chest. Okay. And here's the next question. True or false, the pulmonary lymphatics are anastomosed during lung transplant? A lot of people are saying false for this one. Okay, yeah, so let's talk about another post-surgical complication, and that's pleural effusions. So pleural effusions right after surgery are common, okay? And basically almost every patient who has a lung transplant will have a pleural effusion on the side that the pleural effusion is, or bilaterally. But they usually resolve after a few weeks. But because the lymphatics are not also anastomosed during the surgery, because the lymphatics are tiny and they're sort of everywhere, then the pleural effusions can take a long time to resolve because of that reason. And then also because of just the postoperative state, the patient might have other complications. You can have blood in the pleural space, chyle if there's a thoracic duct injury, or infection and empyema. Okay, and over time, if the pleural effusion takes a long time to resolve, then the fibrin can deposit on the visceral pleura and the parietal pleura and cause the pleura to thicken and calcify, much like a patient with asbestos-related pleural disease. And if that happens, then it impairs the expansion of the lung, and patients can get chronic atelectasis or round atelectasis. Okay. And then another bad thing about lung transplant is that the left and the right chest cavities are frequently connected with each other when you do a bilateral lung transplant. And this is something called a buffalo chest. So if you have a pneumothorax on one side, it'll probably go to the other side. If you have an infection in one side, it'll probably go to the other side. Okay, so pleural disease is a common manifestation of, or a common complication after transplant. And this is another complication that you see, and it's a result of having a long-term pleural effusion, and that's trapped lung. And when you have this fibrin deposition on the visceral pleura, it causes the lung to not be able to expand to fill that space, and it's called trapped lung. Okay, and this can resolve, but it may take a long time to resolve, and in some cases it might require decortication, or they might just leave it like that. Okay, next question. 5 days post-op, what do you think is the most likely diagnosis? So this is the chest CT that we're referring to here. So what you can do is put in a response, and then if you see a response that you like, you can upvote that response. That's how this one will work. Okay, a lot of people are upvoting acute rejection, and that is certainly in the differential, so let's talk about that. So, primary graft dysfunction is something that happens because of the ischemia time. So basically, when um, the the lungs are hooked up, there's a diffuse alveolar damage um, process that can occur, and you'll see ground glass opacity in the lungs. Okay, and that's called primary graft dysfunction, but it's really a diagnosis of exclusion. Okay, because other things can happen in that acute period, like within 10 days, like acute rejection, like you said, pulmonary edema, pneumonia. Okay, so really the differential for airspace disease within the first 10 days is pretty broad. But one of the things that's kind of unique in the lung transplant group is primary graft dysfunction, or you can sometimes it's called reperfusion injury. Okay, and these can be life-threatening, but usually they go away, and it's a diagnosis of exclusion. Okay, and here's this is what it looks like on chest X-ray. Okay, and really it's impossible to tell reperfusion injury from other nonspecific consolidation in the lung, like pulmonary edema, pneumonia, etc. Okay, and then another surgical complication that you might see is clamshell dehiscence. There's something called a wandering sternotomy wire, and that's a sign of a sternal dehiscence when you have a median sternotomy. And usually what you'll see when you have a dehiscence is like all of the sternotomy wires will be lined up except for like one or two, which will be like out to the side, and that's a sign that like you have sternal dehiscence. So this is kind of like a wandering sternotomy wire, but with a clamshell dehiscence. They should be lined up like this. This is the postoperative image, and this is like, I think it was like 3 or 4 weeks later. They look like this. And on CT, what you can see is that the sternotomy wires have basically cut through the bone. So this one only goes through this part of the bone, and this one only goes through this part of the bone, and there's fluid in the middle. Okay, and one of the things that may predispose to this is that, well, first of all, the immunosuppression, but second of all, in order to do these clamshell sternotomies, the internal mammary arteries and veins are ligated. So the wound healing is not as great for these cases because of that fact. Okay, let's talk about our next big category, which is infections. And I have a question for you, which is associated with the reverse halo sign? Okay, I'm seeing a lot of Aspergillus and CMV, so we'll talk about that. The answer has not been said so far. So infections, there's a lot of reasons why infections occur in patients with lung transplant. One of them is, the lungs are exposed to the atmosphere, so it's in direct, contact with the atmospheric air. Okay, but then also there's denervation, so you might have a blunted cough reflex in patients with lung transplants. There's impairment of lymphatic drainage. There's poor mucociliary clearance, and then of course just the immunosuppression. So let's talk briefly about airway infections. Most of the time, airway infections are going to be from Pseudomonas and Staph aureus, and these infections may involve the lung as well. Of course, we are not able to diagnose what type of infection the airway has. Aspergillus tracheobronchitis is another bug that can infect the airways, but on imaging, it'll look identical to infection of other causes, and it'll look identical to ischemia. It'll look identical to necrosis. Okay. Aspergillus tracheobronchitis is a particular bug that can affect the tracheobronchial tree because it's sort of in the air, and the fungus feeds off of dead or decaying material. So if you have necrotic material in the airway, then the Aspergillus organism can start to feed off of that. So it's not necessarily an infection if you have it in the airways, but if you have symptoms, if on bronchoscopy it looks like there's redness and other signs of infection, then that's deemed an airway infection. Okay, and Aspergillus tracheobronchitis is something that you can see that only involves the airway without lung parenchymal involvement. And then this is something that you'll see in the first 3 months after transplant. Okay. The signs on radiology, though, for airway infection are nonspecific. So in terms of lungs and pneumonia, bacterial infections are going to be common, and these are the most common infection that we see in the transplant patient, and it can happen in the early period, it can happen in the late period, and it has a reported incidence of 66%. This is a patient who has MRSA, and they have consolidation down here in the right lower lobe, which looks like any garden variety bronchopneumonia, but this patient also has cavitary pneumonia in the left upper lobe. Okay. Viral infections, CMV is the second most common infection after lung transplant, after bacterial infection, and CMV is particularly bad because it is one of the factors that leads to later on down the line bronchiolitis obliterans, which is one of the syndromes of chronic lung allograft dysfunction. But CMV occurs particularly commonly if the recipient is naive to CMV and the donor is positive for CMV. But it can also occur in other situations, like as a reactivation of a latent infection. And this is usually something that happens in the first 6 months after transplant. Okay. The findings of CMV infection in the lung are nonspecific. It can include ground glass opacity, it can include consolidation, it can include central lobular nodules, and tree and bud opacity. Okay, so that's CMV. But now they test for CMV in the donor and the recipient, so the incidence of this may be decreasing a little bit, but it's still a very common infection. The other common viral infections include HSV, adenovirus, and influenza virus. Okay, and these kind of all have nonspecific features. Adenovirus maybe a little bit more can look like a bacterial pneumonia than the others, but really these have kind of nonspecific features. EBV I called out specifically because EBV is associated with post-transplant lymphoproliferative disease, and we'll talk about that in a second. And then fungal pneumonia. So early on in the disease course, fungal pneumonia is mainly from Candida, and that occurs early within 1 month, and that can include the airway. It can include other things like the esophagus, like Candida esophagitis. It may include the lung, although that's not as common. Aspergillus can occur at any time in the lung, but most common in the first 6 months. Patients with cystic fibrosis are at higher risk because the other lung already has like the Aspergillus species in it, usually from ABPA. And patients with lung transplant may lack the classic halo sign that you see in other patients with angioinvasive aspergillus. Like in this patient with aspergillus, it just looks like kind of a bronchopneumonia pattern with clustered nodules and then diffuse ground glass. Okay, but this has a high mortality. Mucor is also a disease that patients with lung transplant can get, although it happens infrequently, like 10 times less than aspergillus does. However, the reason why it's important is because voriconazole is not effective for mucor, and mucor is usually a very aggressive infection. And the classic CT sign for mucor infection is the reverse halo sign. So let me show you some examples here. So this is an Aspergillus pneumonia. This looked almost exactly like that MRSA pneumonia that I showed you before. But notice that these are just nodules, one area of nodular consolidation with a halo sign and one area of cavitation. Okay, so I try not to really talk about what infection I think it is because we're just notoriously bad at calling the infection based on the radiographic findings. Okay, if there is cavitation, I mentioned that, and I mentioned that it could represent fungal pneumonia, but I don't try to really go any farther than that, except if I see the reverse halo sign. And the reverse halo sign is more specific for pulmonary mucor than it is for aspergillus. And I say mucor specifically if there is a reverse halo sign because of the fact that voriconazole and fluconazole don't work for mucor like it does for aspergillus pneumonia. Okay, so the reverse halo sign is something that's more specific for mucor. Okay, and then finally, mycobacterial infection. So mycobacterial infection can be non-tuberculous or tuberculous. And what you'll see is the same thing that you see sort of in other TB or non-TB infections, which are tree and bud opacity, bronchiectasis, bronchial wall thickening. Okay, and if it's TB and not non-tuberculous TB, then you will see classic signs, including cavitary lung disease and tree and bud opacity. Okay, but this is a late complication. Okay, let's talk about the immunologic complications. And I have a question. What is the most common form of chronic lung allograft rejection? Okay, so a patient with chronic lung rejection, what are you going to see on CT? What's going to be the most common manifestation? Okay, most people said bronchiolitis obliterans, which is the correct answer. So let's talk about rejection. So the immediate complication, immunologic complication, is hyperacute rejection. And what hyperacute rejection represents is that the recipient has preformed antibodies to something in the donor. Okay, and this is what'll happen is when the lung is hooked up and the blood starts flowing into the lung, then even in the surgery itself, the lung can become very edematous and boggy, okay, and rapid deterioration can occur. And this is really rare nowadays because, I mean, unless some kind of error was made in terms of the testing, then hyperacute rejection is really not something that we see nowadays. Acute rejection is seen frequently, though. Acute rejection is a reversible type of cell-mediated immune response to the donor lung, and it's something that can occur early, like within a week or a few months after surgery. And as you go out past 6 months or so, the frequency of acute rejection decreases. Okay, but the more instances of acute rejection you have, the higher the likelihood that you'll have chronic lung allograft dysfunction, CLAD. It used to be called chronic rejection, but it's now called CLAD. Okay, the signs on chest X-ray for and CT for acute rejection are septal thickening, ground glass opacity, and consolidation. So unfortunately, they're not really very specific. But these are the signs: septal thickening, ground glass, and consolidation. So it sort of looks like pulmonary edema. These respond to steroids and immunosuppression, and transbronchial biopsy is necessary to establish the diagnosis. Okay, and patients who have a lung transplant, our protocol here is that whether they are exhibiting signs or not of rejection, they will have a bronchoscopy with biopsies to rule out rejection at 1 month, 3 months, 6 months, 9 months, and 1 year. And then after that, it occurs variably, but generally every year after the first year. Okay, so patients will have routine transbronchial biopsy to establish the diagnosis. But this is what it looks like on CT. This looks exactly like pulmonary edema with interlobular septal thickening. It looks like lymphangitic carcinomatosis, right? And this is a case where there's more consolidation, peribronchial consolidation, and interlobular septal thickening. And then notably, like it'll only occur in the transplanted lung. Okay, this is so if you see bilateral interlobular septal thickening, that's more likely that it's going to be pulmonary edema. Whereas if it's only affecting the transplanted lung in a unilateral, then that's more likely going to be an acute rejection. Okay. Now, chronic lung allograft dysfunction, or CLAD, is what we call now chronic rejection. Okay, chronic dysfunction of the lung transplant has multiple etiologies. One is repeated infection, repeated acute rejection, and chronic aspiration. Okay, and there's two major syndromes that are manifest by that CLAD will manifest as. Most of the time, CLAD will manifest as an obstructive type picture, 70%, whereas a minority of the time, 30% will have a restrictive type picture, okay? So the obstructive phenotype will look like bronchiolitis obliterans, okay? Bronchiolitis obliterans is a disease in which the small airways of the lungs become fibrosed and obstructed, and early in the stages of bronchiolitis obliterans, the only finding that you may see is air trapping. So on it, if you just have an inspiratory image, the lungs may look completely clear. Okay. One clue though, on an inspiratory image, if the lungs look too dark, you might be looking at bronchiolitis obliterans. Okay, so you have to have sort of a database in your mind of what normal lung density looks like. But if the lungs look too dark, then you should think about bronchiolitis obliterans, particularly if they're like 6 months out from their transplant. Okay, now if you have an HRCT, then you will have expiratory images and you'll be able to see that the areas of dark lung stay dark when the patient exhales, and areas of normal lung become more white when the patient exhales. Okay, and that is the classic sign of bronchiolitis obliterans. All right, so this is very common. 50% of patients at 5 years will have it, and it usually occurs at 6 months or greater. Later on in the disease course of bronchiolitis obliterans, you'll have bronchiectasis and bronchial wall thickening, like in this patient. But early on, the only thing that you may see is just the air trapping. Okay, and here's another case, the same thing. Okay, the restrictive phenotype is a decline in the total lung capacity, 90%. Less than 90% of baseline. By the way, there's clinical criteria for bronchiolitis obliterans, which is a decline in the FEV1 to less than 80% of the best post-transplant baseline. And this is the clinical definition for the restrictive phenotype, decline in total lung capacity less than 90% of baseline. Okay, and what you'll see on radiology for the restrictive phenotype is basically fibrosis in the upper lungs. Okay, and on path it'll be idiopathic pleural parenchymal fibroelastosis, or IPPFE. So anyway, this is what it looks like on path. This is kind of a rare type of idiopathic fibrosis, but it's something that is seen in transplant patients. Okay, so here we go. Bilateral upper lobe predominant pulmonary fibrosis. In a transplant patient, think restrictive chronic lung allograft dysfunction. Okay, let's talk about neoplasms. Next question here. What is, do I have this question right? Yeah. Most PTLD in lung transplant occurs when? I'm just going to clean this here. This is dirty. Okay. Let's see what people said here. After the first year, within the first year, after the 5th year. Okay. And how about this question? PTLD is most common after which transplant? Okay, most people said lung. All right, so let's talk about that. So there are many different cancers, well, not many, but a few different cancers you can get after lung transplant, and one of the reasons is you have a decreased immunity, and then also there's oncogenic viruses that are potentially causing these. So PTLD is one major one you have to think about. Kaposi sarcoma is kind of rare. Lung cancer is another one you have to think about, and then skin cancer is something that we don't have to think about, but it's clinicians have to worry about. So PTLD occurs in about 5% of lung transplant patients, and it usually occurs within the first year if it's going to occur. It's more common in thoracic organs compared to liver and kidney, meaning lung transplant and heart transplant are more common. And actually lung transplant is the most common. And then patients who are EBV seronegative, so if the recipient is EBV seronegative, then they have a 20 times greater risk of PTLD. And then these cases of PTLD can be mild, and all you have to do is increase the or decrease the immunosuppression, and it can go into like a full-blown lymphoma type picture. Okay, on radiology, you can see single or multiple nodules or masses, consolidation, enlarged lymph nodes, and pleural effusions. Okay, and cases of PTLD where there's in a lung transplant, there's going to be more often lung involvement compared to other organs. So here's some more examples. So just a mass in the lung. That's PTLD. This has that classic mass with air bronchograms look of pulmonary lymphoma. This is another mass in the lung, or perhaps it's a lymph node, I'm not sure. And then Kaposi sarcoma. Kaposi sarcoma is associated with HHV8 infection, and this is a late complication. And typically, patients will have other sites of involvement in addition. Just 1 second. Hold on 1 second. Hey. Oh. Yeah. Okay. Patients with lung cancer can also have lung cancer is another complication, and it's a late complication occurring after 1 year, and particularly in patients who have COPD. Okay, so what you have to do is look at the native lung. So if they have a unilateral transplant, look at the lung that's natively there, and scroll through it looking for nodules as you would in a patient who has COPD, because the frequency of these lung cancers in patients with transplant is higher than the general population. Reported frequency is up to 7%. And then skin cancer. So there's an increased risk of squamous and basal cell cancers. Okay, and then miscellaneous complications you can have is recurrence of the primary disease, with sarcoid being the most common. Cystic lung disease is another thing. And then organizing pneumonia is another thing that you can see. Okay, so we're not going to talk too much about that. So I have a few questions for you. Which primary disease recurrence is this? This is a patient with a transplant. Which primary disease recurrence? Let's see what most people are saying here. Alpha 1, all right, I like that. How about this? Which primary disease recurrence is this? That was alpha 1. It was a basilar predominant emphysematous process. How about this one? What do most people say here? Okay, so this one is sarcoid. Oops, I'm on the wrong one here. So yeah, that one was sarcoid, which most people got right. And then the last one is this one. Okay, so this is PLCH. Okay. All right, so let's do a knowledge test. few quick questions here. Which is the most common bronchial anastomotic complication post-lung transplant? And this is an upvote question. Most common bronchial anastomotic complication. I'm going to answer here also. Okay, good. Stenosis. How about this? What class of bugs is most common to cause pneumonia after lung transplant? Okay, most people are saying bacteria, which is correct. Bacterial are going to be more common than fungal or viral, although CMV is pretty common. Bronchial wall defects less than what size are associated with a good prognosis? Yeah. 4 millimeters. Good. Okay. So, to summarize, oops, you can't see the text here. Okay, yeah. So, remember, try to chunk all these things together. Remember the surgical complications: anastomotic dehiscence, infection, stenosis. The pleural disease can last a long time. Remember, primary graft dysfunction is a unique. Let me just put all these up here. Is a unique complication of lung transplant recipients. Okay, immunologic complications: acute rejection will look like pulmonary edema. Chronic rejection, most of the time, looks like bronchiolitis obliterans. A third of the time, it'll look like upper lobe fibrosis. Remember pneumonias, okay? So reverse halo sign with mucor. Bacterial infection, most common. Aspergillus, pretty common. CMV, pretty common. Recurrent disease is something that can happen, okay? So watch out for that, usually a year after. And then look out for new lung cancers or PTLD. Okay, does anybody have any questions? You can put a comment and I'll try to answer that. Does anybody have any questions about lung transplant? No. Okay, well, thanks. That's it.